Okay, and away we go. So you should all be able to see my screen. These are the same slides that I attached to the meeting invite yesterday. So this is our office hours for the proposed significant changes to the 2026 CCO contracts, specifically the financially related changes. And those of you who attended our first office hours last Friday, you'll recognize these slides because they're literally the same slides. So for some orientation to what this office hours is, so this is a brand new addition to the annual restatement process. It's part of our commitment to the legislature from just a month or so ago. And I want to acknowledge that this is not a perfectly oiled machine. This is a learning opportunity. So we will work on improving these office hours this year and definitely in the future as we have more experience doing these. This is not a structured conversation. It's not like we have an agenda full of items to discuss. This is an open opportunity for discussion between CCOs and OHA folks. And I want to remind everyone that our overarching interest is solutions that are in the best interest of our shared OHP members. So this is going to be in the weeds. We're going to get deep in some of these topics. If you have, we want you to share your questions, your concerns, your suggestions for improvements, because ultimately we want to get these proposed significant changes in the best shape possible when they're officially considered for approval. So the ones on deck today, as I mentioned already, are financial related changes. And they are all technically discretionary changes. Some of them have a connection to the legislature in terms of needing budget authority to actually implement some of these. So you can see on this slide and the second slide with this table that there are 11 total items. These are actually not in any particular order right now because we're going to poll the CCOs because we want to focus on the proposals with the most interest and have our discussion focus on those. So I'm going to launch that poll in just a moment. And I want to acknowledge too that what I have in this slide deck is what some of y'all have already seen as the slides presented for each of the changes in the past CCO meetings, whether it was contracts and compliance last month or operations collaborative earlier this week. So I'm going to go ahead and launch the poll and we'll give it a couple minutes. And the poll is only for CCO representatives. So OHA folks, sit on your hands. One moment to launch the poll here. Okay, and we're going to click launch. And so you may have to scroll down to display the entire poll, but there's a box for each of the 11 changes. And of course, you can mark as many boxes as are applicable to you. See what this is looking like. Okay, oh, look at this. Okay, so you guys can't see this yet, but the results, a lot of interest in the HSN climate risk corridor topic. Nothing yet about the GME directed payment. And we'll, looks like we only have 4 responses so far. So good morning, Chris Park. We're doing a poll right now for interest in which topics we want to prioritize for today's discussion. And we'll give it another minute.
Cheryl, the poll
Yeah.
doesn't seem to be working for everybody. I'm not quite sure.
Okay. Interesting. Oh man. Okay. Well, let me launch it again, if it will let me. Okay. Let's see. I'm going to click close poll, and then I'm going to see if I can redo it. Okay, so I'm going to click reopen poll. Okay, so let's try it again. And if folks have any difficulties, let me know right away, okay?
I'm still getting the error.
I'm still getting the error.
Now it looks like, oh man, looks like it is working for a couple of people. Okay, let's see here. Let me close it again. Okay. Let's see here. Yeah, it's definitely not working equally for folks. Okay, I'm going to open it one more time. I'm going to cross my fingers. Okay. Let's try it again. Oh, hey. There's 10 responses
That
now.
doesn't seem to be working.
Beg pardon?
It still doesn't seem to be working.
Yeah, it looks like it's really hit or miss because we have 12 responses now, which is better than the 4. There's 13.
Cheryl,
Yeah.
This is Kathy with Kaiser. I noticed that if you populate it in the message in the chat, that's part of Teams, where it's live, it doesn't work. But the little window that pops up, if you do it on there, it does count it.
Thank you for the tip. So folks, if you heard that, use the pop-up box that shows on your screen, not what's in the chat.
Maybe that's the problem because I'm not getting the pop-up
Really?
on my screen.
So I don't have a great solution for this. No pop-up, huh? Well, so why don't oh, some might have their pop-up disabled. Good point, Chelsea. So let's see here. What I want to do is I want to give folks an idea of what is showing as priorities in the results I'm seeing right now, and y'all let me know if this is consistent with the interest. So there's the majority of the interest so far is the interest in climate non-risk to risk corridor, and then the dental directed payment is second. So does that ring true for folks generally? Kind of give me a hand raise or something like that. Let's see here. And what about, let's see here. I'm not showing anything for the culturally and linguistically specific expansion for that directed. That seems a bit odd. Let's see. So Emily, you note that you're in the Teams app. Is it working for you there or not? Okay. Yeah, guys, I don't have a good solution here because my only way of handling this was this poll. So why don't we go ahead and start with the interest in climate risk corridor. Oh, and so we have a different response from Amy. Why don't we go ahead and start with the risk corridor, then we'll move on to the dental DP, and then we will have to wing it a little bit on which other ones we cover. So I apologize if this isn't working correctly. It did work perfectly well last Friday, so I apologize for that. So I'm going to go ahead and close the poll. And I'm going to put in the chat what the results look like right now. hopefully you can see this. I'm not sure whether what's displayed in my chat with the same information already also shows up for you, but this is what the results look like as of right now with only 14 responses. So I'm sorry for that. So we're going to go ahead and move on to the climate risk corridor topic. So what I'm going to do is I'm going to move the slideshow to that so that we have for reference the description of that change. So, and I believe Chelsea is going to be leading us on this one with an assist from Jake. So since this is unstructured, we can just start having hand raises, and my role will be to call on folks and also monitor the chat for questions.
Good morning, all.
So I am looking for raised hands. So I'm not seeing any raised hands. I hope it's not just me. Oh, Amy Burns, thank you. You saved the day.
Good morning. Can you hear me?
Yes.
Hi. Hi, Chelsea. I think one of the questions that came up on Tuesday that we're curious about is how this would be developed, since we don't have a lot of past experience to go on. And it's those of us who work in the HRSN space are kind of aware of the fact that there are a lot of variables that can affect whether or not this is really going to be a stable, continuous demand for these services. So could you perhaps talk about what the OHA is looking at in developing the risk corridor and how it would work, and what we could expect?
Sure. Thanks for the question, Amy. In terms of kind of where we are with HRSN, we have the most experience for climate, and we also have the most experience for climate in our past data in the targeted months of when it was at its highest peak, right? When around that summertime. The non-risk settlement was well documented. It didn't, we have some really good data from that. Encounter data has lagged significantly, so we are concerned about that. One of the pieces that we've been talking about internally and is very open to feedback from the CCOs is building it into the capitation with more of a one-sided risk corridor on the top, meaning that you would receive money in your rates. It would not be a non-risk, so it wouldn't trigger an encounter and then a repayment, but you'd receive your capitation, you'd use that to pay for it. And if it went over, we would settle. Part of the reason we'd like to move more things into the capitation is to improve cash flow. A lot of CCOs, I think, are seeing some lags in that just because of encounter data submission. Then it goes into repayment. This is very open to feedback, but our goal is really to start moving things into the capitation as we can and when the data makes sense. Some of the things that don't necessarily make sense in the capitation, especially right now, is some of the housing, just because of the demand and how that's moving. Those services are very different, and they're also temporary, meaning they have limits on a member or a household. For climate, though, I think there is some track record. We also have a lot of HRS data in the past, and there are specific CCOs that do a lot more in this area than others. Some of our Southern Oregon CCOs have very high utilization of ACs compared to others, just as an example. So trying to do that more at a CCO specific add-on, but then having kind of a top end risk corridor is what we're thinking. Again, this is very open to feedback. We are trying to move towards that. In the very beginning of us moving to the non-risk, we were hoping to move things into capitation quicker. But I think this is the only one that is viable at this time for 26. Happy to take more questions.
So not seeing any more. Oh, Amy, yes, again, please.
Hi, sorry, just as a follow-up, how are you going to calculate the admin for this? Will that be incorporated?
So I think that's a great question. So anything that's non-risk, the admin has to be separately kind of developed and put together. And I know Laura's on the phone, so she's happy to jump in. This becoming at risk, even with some cover, would then be incorporated in the regular capitation admin. So we'd want to look at that and see if there's any adjustments we need to make. But we expect that it would just flow into the base with the regular admin associated.
Yeah, there's a question from Jacob in the chat, Chelsea, and also a comment from Josh.
Yeah. So Jacob, let me try, because I think this might dive into the HRSN admin settlement question. So there's two forms of admin from a CMS perspective. There's at-risk capitation admin, which includes margin and profit. And then there's base admin, which is on the non-risk side. So your non-risk admin does have more limitations in how it can be built, partially because there's no risk at all to the CCO. So that piece of it, we'll call it the non-risk admin component, will still exist off of all the other services that aren't climate in 2026. But HRSN climate would then be eligible for kind of the at-risk admin, which includes profit and your base kind of tiered admin percentages, along with having some cover on higher need with that risk corridor. So I don't know if that answers your question, but currently it's kind of a two admin world and just moving HRSN into your capitation admin build. I hope that makes sense. Okay, I got a thumbs up. Hopefully I said it slow enough that it made sense. Increased legal pressure. Josh, I appreciate your comment. I think one of that is exactly why we would think a risk corridor would still be important, just in case there was a significant volume or demand that would occur to a CCO at one time. So kind of protecting that top end risk, but having some money in your capitation to pay versus kind of the reimbursement model that we're in for climate right now. But happy to talk more about that, Josh, if you want to. Go ahead, Amy.
Yeah, we're still kind of processing this, but I think one of the concerns that at least my organization had was the having to pay back if we had underutilization. But what you're saying is that wouldn't be an issue. It would just be, how did you phrase it? The top end?
Yeah, it's a one-sided risk corridor. We've done them in the past.
Mm-hmm.
It only is on the top. It is subject to CMS's approval and their feedback. But essentially it would be I would say a conservative capitation amount, and based on past experience, obviously is somewhat lower in 24 than potentially 26. So we put some trend on there, obviously look at some seasonality, especially with climate. Smooth that out, put that in your rates, and then you'd be protected kind of on the top end, meaning that OHA would pay out if you had a lot more volume.
Yeah, I think that makes a lot of sense. One of the things that I brought up on Tuesday was that there's some possibility, since it's one device per member per 3 years, that we might have saturated in some cases our membership. And we, like with Hep C, we did see where we got to the point where we've treated the population to a point that the risk corridor, at least for my organization, meant that we were paying back year after year after year to the OHA. So I like this idea. So thank you.
Yeah, no problem.
Looks like we have Trent from IHN.
Yeah, thanks. From the CCO, the operations meeting, I think that you guys are worried about us bringing out the pitchfork, so I make sure to grab a pitchfork. But no, I think my question for Chelsea is, are you seeing in the climate data kind of a smoothing you mentioned? And it's more of a concern on my end in that,
Yeah.
the climate devices aren't a normal, health benefit in that, members generally don't want to see their doctor, unless they're sick. Whereas climate is one of those things where if you want an air conditioner, yeah, I'd take an air conditioner, right? So there's that different kind of dynamic economically. Um, but I guess my question, are you seeing enough smoothing in the data then to start to forecast that out? Or is it just, I guess my thought is it's a different type of benefit. So I don't know if the actuarial trends apply the same way, but maybe you can answer that in what you're seeing in your data.
A little bit. I will say we are having some data lag issues after August when MMIS went live. I know that our data team and our HRSN team has been talking to your HRSN representatives a lot about this. But the data is really good for the non-risk settlement that was March through July. And one of the pieces that I think is important is understanding the differences by CCO and what happens both in their operational implementation and also the geographic impact. It was very evident that our Southern Oregon CCOs had a lot more air conditioners. They also have been set up to provide more air conditioners in the past. And so I think that piece is important for us to acknowledge in the rates. In terms of the data, I guess there is seasonality with this that we did expect and we did see in the data. So I would say it confirmed a little bit of our expectation trend in terms of what we budgeted versus what we saw in terms of ramping up, right? June and July. June was a little lower. July got much higher. We expect July and August to be very similar. August is still filling in from MMIS, but those would be kind of our higher months, and then it tapers down. In terms of what that smoothing would be, I think we'd be doing a little bit of it on our side as well against the operational differences between CCOs, putting that together and, adjusting. And I think the piece that's important for the CCOs to be thinking about as we go into the rate setting is do you expect things to be very different in terms of how you operationalize climate in 24 to 26? So is there some pieces that you'd like to bring forward to say we're going to do this differently? We put different things in place for 25. We expect that to increase ramp up in 26. That would be very helpful feedback. But again, just being candid, we'll use the data, we'll project it forward, and then you'll have some protection on the top end is what our plan is. I see some questions. Thank you. Backup plan if CMS doesn't approve this high side or possibility. So in terms of a backup plan, Josh, I think the backup plan would just be it continues in non-risk world. So the kind of current state. Which I think is fine. Generally. Okay. It sounds like things are going well. Again, this is still in a conversation state in terms of your guys' feedback. We're going into this into the rate development and gathering more data. We just got our annual data pulled at the end of March. So really trying to understand some of the pieces if data is flowing, how you guys feel about those conversations in rate development. I think that's a lot of what we want to talk about. There'll be, there's a little risk to this process, right? But you'll also receive some profit in your admin, but it's still going to be very protected on that top end. So if you see extreme demand, you'll be eligible for a settlement. Parameters and all of that would be done. We'll talk more about that in the rates work group as we go forward, and we'll love your feedback on that. Think that I covered things. I'm seeing some thank yous in the chat.
Yeah, some nice appreciation from Larry there. So any more questions or comments about this particular? Oh, Jenna, yes, go ahead.
Yeah, just one quick comment. I think for the CCOs, whenever anything is being moved into capitation, one thing that would be really helpful to have clarified in like the capitation rate setting side, and just for the sake of the 3.4% cap and how that is being calculated, just being very clear if it's something that's truly funded separately under a different waiver and we have those dollars being moved into capitation, keeping that separate and not applying that into the year over year change that's being measured against the 3.4%, and making sure that that's clear even in like the Mercer documents, I think is really important to the CCOs.
Thank you for that. Yeah, I think our terminology we like to do is funded and unfunded in terms of how we separate them out. This is a funded change, right? We're moving money from one place to the other and would not be subject to 3.4. It's also very small, so I'm just gonna say I'm not gonna move the needle very much on the CCO program related to trend or budgetary pieces, but it will be called out separately in how we set the budget, understanding that that's a really key piece. And when bigger items move forward, I completely agree with you, Jenna, that is an important shift. Just to remind everyone, right now, the federal government is paying 100% of these services through what we call a dish fee program. So we do need to work with CMS to make sure everything is meeting their needs. We are allowed, based on our STCs right now, to move things into capitation. There was some limitations on that at the start of the demonstration. That's why it wasn't moved to capitation right away. We were required to put it in a non-risk contract. And so moving it into capitation is something that will require a lot of TA with CMS, but we checked all the boxes to move it forward based on our STCs. So we feel like we're in a good place there. Thank you for calling out the 3.4 though. I appreciate that. Okay.
So I think we have exhausted the questions and comments for this topic. So unless someone raises their hand right now, we're going to move on to the dental directed payment. And I think that's John. But Chelsea, you can't go anywhere because you might be on some of the other items. So, but you can go off screen if you want to.
I can help with dental too. So.
Cool. So I'm going to move the slide deck to the dental directed payment, and John, you can go ahead and start talking and introducing yourself real quick.
Hi, I'm John Walker at OFA. I work under Chelsea. Unfortunately, I would like to provide as much information we can about the dental directed payment. There is a lot still up in the air. We are finishing up another round. They have sort of a single short question of getting approval from CMS for our current dental directed payment. We are also just now getting our first real data about utilization so far this year. And just to kind of place set all this, we put in place the dental directed payment because if we didn't, utilization had gotten so low post-pandemic amongst adults that it would have had to result in sort of a dental rate cut. And so we really envision the dental directed payment kind of a stopgap measure to keep the rate steady. And we have seen some improvement this year in the adult population in dental utilization. So unfortunately, we're still waiting on CMS approval for the current directed payments for this year. And whether or not or how big of dental directed payments we might need for next year is a maybe, as far as we can answer based on the existing data. So I wish I could provide more clarity at the moment, but I am trying to be as forthright as I can as we prepare for this, because we sort of spin up the cycle of getting feedback on any changes to all directed payments, sort of about next month. Then we really got to sort of figure out the nuts and bolts of them in the summer. Then we submit to CMS in sort of a September timeframe. That is all I think I can provide it now, and then we're happy to answer what questions we are capable of answering at the moment.
Thank you for being so candid, John. So do we have any questions, comments, thoughts? Yes, Dr. Chaudhry.
Hi, good morning. Thank you for the opportunity and privilege to be here and speak a little bit about my take on dental directed payments. And so for full transparency, or not I, but Capital Dental Care contracts with 12 different CCOs across the state. And so I do want to say that I recognize the original intent of the dental directed payments, which was to restore utilization to pre-pandemic levels. And I believe that the dental directed payments are the methodology to really kind of get us to where we need to be. Um, I feel as though that while you've been very transparent in terms of the intent of why we're doing this and why we are where we are and what could potentially happen in the future. At the same time, I also believe in having clear utilization benchmarks and an appropriate evaluation of provider network capacity to potentially phase a reduction model. I really believe in the idea of the dental directed payments in order to provide a little bit more grease in the system or oil in the system to get things moving. And maybe if possible, again, if we could have a clear idea of where exactly the utilization levels are and what are our true targets that we're trying to achieve. That would be greatly appreciated.
Chelsea, do you want me to handle this or you want to handle this?
Yeah, I'm happy to handle that. Thank you, Dr. Chaudhry. I'm curious, because one of the pieces that's really nice about the directed payment model is there is kind of an evaluation process, but one of the issues is the lag. And so I think from a 2025 perspective, evaluating kind of where we landed with it being in play and then instead of being live for 25, how that improved utilization, we won't know that till, mid next year. And the rates for 26 will already be built. So I'm curious what your thoughts are in terms of that timing and how that may impact your comments for the dental directed payments for 26. But only if you wanted to comment on that, because I just want to make sure I understand what your intent is in your comment for 26.
So what I interpret from your question is that we don't have enough data to kind of foresee what the program could be for 2026. Is that correct? Did I interpret correctly?
I think the piece that's tricky is the timing of what we implemented for 25. Granted, we need to get CMS's approval before money can go out, but we're hopeful that approval is coming. What we've implemented in terms of expectation of new providers coming on or increased retention and access for existing providers, that would occur for 25. We won't have 25 data until we're setting 27 rates. And so for 26, we have limited data to understand the impact, except 24. We have 24 and 24 did see a bump in utilization based on our initial review, which is a good sign. But I think it's hard for OHA to see what's happening on the ground in 25, if there's a lot of change occurring or not, because of that data lag. It makes it difficult to make decisions into 26. It might be that we just shrink the directed payments in terms of what available money we have to put there, changing the numbers, that kind of thing. Or it could be looking at a different type of directed payment. There's also a lot of legislative activity on dental. And so we want to be mindful that that could also impact what we do in the 26 or 27 rates. I'm not sure if I asked a question there, Dr. Chaudhry, but I did try to provide some discussion on kind of our thinking and what we're up against.
Thank you very much for sharing that. And I believe that question should be posed across all of the dental stakeholders and the CCOs. I will have to think through that a little bit more, and maybe I can follow up via email. But it's definitely an intriguing a discussion point that requires a little bit of thought in order to make it meaningful and appropriate. So I'll take that back. But thank you for raising it.
I think, Cheryl, could you go to the question slide for this one?
Give me just a moment here.
Thank you. Because I think some of the pieces are tricky is because of the delayed approval. And so, providing input in writing about how the directed payments could be improved for next year, maybe ratcheting up or down, depending on how much money is available. So what's the most beneficial part of the directed payments that could or potentially should be prioritized in 26, if we have some room? Or what would be, helpful? Is it just the bundles, the minimally invasive bundles and preventative bundles that we should continue? That should be the top priority. I think that would be really helpful feedback at this point. And then if there's any other items to be considering, I think that would be helpful. So if you want to work with your dental partners or the dental organizations and kind of bring some of those pieces forward, that would be helpful. Understanding that operationally, some of the payments haven't gone out, you haven't done the first year yet. You can kind of foresee some of the impacts, hopefully, and provide feedback. That would be wonderful if you can put that together, and happy to take that in writing. Okay, and Larry, I did see your question. A lot of CMS's concerns haven't been too big, but we've seen a lot of delays in terms of federal back and forth. There was a kind of a closed communication period with CMS for part of this year. And then we saw a lot of activity in terms of directed payment questions. We worked with them. There has been some work that we've talked to the DCOs. We proposed a metric for the incentive payment to ensure that quality was associated with the increase. But once we get that approved, we'll communicate out all of those pieces. But we just had to ensure the bar was appropriately meeting CMS's expectation. But we worked with the dental organizations and made sure it was a feasible piece based on past data. I don't know, Larry, if you have other questions, but there has been some back and forth with CMS on that. But I think we got one follow-up question yesterday, and it seems very reasonable to respond to, and hopefully that will get us to approval.
So looking in the chat, so no further questions or comments on this. And you're welcome, Larry. Thank you. And no hand raises. So unless someone raises their hand right now, we're going to actually move on to the maternity directed payments. And so hopefully we have Nikki and or Tom on the call. And I'm going to move to that slide real quick.
Hi, Cheryl. This is Tom. I think I'm today.
Okay. So I'd be glad for folks to raise their hand or drop their question in the chat. And don't feel pressure to conjure questions, because if there aren't, then we'll move on to the next item. Okay, I'm going to take that as we can move on. So thank you, Tom.
Thanks. Glad to help.
You bet. Okay, then we're going to actually move on to risk corridor. So it looks like the handicapping malocclusion risk corridor, which is Will Clark Shim. Will, are you on the call?
Good morning, Cheryl. Yeah, I'm here. I'll be on camera in just 2 shakes of a lamb's tail.
Okay, not sure how to time that, but okay. So, awesome. So looking for any questions in the chat, any comments, any hand raises? Yes, so Dr. Chaudhry.
Hi, it's me again. Okay, so thank you for the opportunity and the privilege to speak on behalf of the anything related to oral health, and in this particular case, handicapping malocclusion. And so, just as a point of context, as we all know, the handicapping malocclusion risk corridor kind of kicked off in the beginning of 2023, and I do agree that the information that has been presented definitely has started to demonstrate a steady state for the D8080, which is the essentially what that is orthodontic treatment for members between ages 10 to 12. And so at the end of last year, with essentially the orthodontia benefit was expanded on January 1st of this year, such that the risk order now includes orthodontia treatment codes that span ages 6 all the way up to 20. And those specific codes by procedure CDT codes are D8070, the D8080, D8090, and D8091. And so from my perspective and what I've seen in the care that Capital Dental care providers have performed, this has really created not only a programmatic shift, but a paradigm shift in terms of really the impact of the benefit change. And therefore, what I would recommend or what I would suggest is that because of this destabilization of what we understand, I would actually propose that we postpone any modifications or changes related to the handicapping malocclusion risk corridor until we have more data in 2025. So I would recommend the change to occur for calendar year 2027 and not have an impact on calendar year 2026.
Thank you for your comments, Dr. Chaudhry. And I also want to recognize that we received them via writing, which was very, very helpful. Do you have a sense of the kind of proportional increase that we might expect in terms of number of youth who are eligible for treatment pre-January 2025 and post-January 2025?
Are you referencing just the 10 to 12-year-old population, or are you referencing across the 6 to 20?
Across the 6 to 20. So what was previously allowable under the rules through December 2024 were covered versus what is covered effectively for the rules after December, starting January 2025.
So just to kind of paraphrase back my interpretation of the ask is to potentially quantify the amount of potential severe handicapping malocclusion cases for all of the ages outside of the 10 to 12-year-old group that had the ortho benefit prior. Is that correct?
Perhaps, but I think we have seen, I'd have to go back to the data. I think we've seen that in the billing approach set up through December 2024, which you and others had commented on, the instruction from OHA was to apply a single billing code, even though it would cover a range of ages. So we had people over age 12 receiving treatment, as I recall, and under age 10, as I recall. It was a much wider range of ages. So part of what we did for January 2025 is we expanded the rate of codes so that they could be used in accordance with the typical billing parameters and not fitting all the members in a wider range into one billing code. So I'm not sure how much we're actually, I'm trying to gauge, I should say, how much we're actually expanding the available treatment as opposed to just changing the billing code instructions.
Okay. From a clinical perspective, while the Oregon Health Authority had indicated that the D8080 can be used for any orthodontic treatment, the reality is that based on the CDT or the current dental terminology handbook, that's published every year, the D8080, and I don't have the exact description of the procedure in front of me, is that it's specifically for orthodontic treatment, when the appropriate dentition are in the mouth. And so, and by what I mean by that is that we have our second set of teeth, or our adult teeth, are in the mouth. And so what Capital Dental Care experienced is that we were unable to, it was a lot more challenging to bring orthodontists on board who would bill out a D8080 when that wasn't really clinically appropriate to be billing out that procedure. And so I would be remiss to share with you that, based on what you're requesting, even though it was directed by the Oregon Health Authority, we essentially have to align with what the Oregon Board of Dentistry indicates as far as what is allowable and not allowable. And are we essentially over treating or under treating based on the care that's being delivered? So when I had presented the idea that you've just shared now at the Oregon Board of Dentistry meeting back in, I think it was February, end of February of 2023, they made a few comments that supported that it's really up to the licensee to ensure that they are practicing appropriately and delivering the appropriate level of care and essentially documenting the appropriate procedure that is being delivered. And so, for example, the D8070 is actually specifically for what is called transitional dentition, which is when we have baby teeth and adult teeth that are in the mouth. And so I know I'm getting a little bit clinical heavy, and I realize Dr. Frog is not on the call, and I don't want to waste anyone's time, but hopefully that provides a little bit more context of, while it was the original intention of the Oregon Health Authority, there were a lot of challenges from the Oregon Board of Dentistry and from Capital Dental Care providers with being able to properly provide care, under the age of 10, above the age of 12, with the utilization of the D8080 code.
Okay, I appreciate the feedback.
Thank you, Dr. Daughtry. I actually rather enjoy hearing the in the weeds conversation about this because it really does give some nice context to the concerns about this. So I'm looking in the chat. I don't see any further questions or comments. Oh, Jenna has her hand raised. Go for it.
Yeah, I think I don't see any of my ODS community dental partners on here, but putting on my ODS hat, I think that I would agree with some of the utilization. It's the same thing that we just talked about with the dental directed payments in terms of the timing and the utilization. With the change, I think that to just apply standard trends on the handicapping malocclusion treatments, I don't think that we've actually seen that the potential utilization or have enough run out to have a great sense of what that could be. I would, if this, don't get me wrong, I would love to see risk corridors go away because they are an administrative burden. So I definitely hope that we get to a place where the risk corridors can be removed, but I do think that there is some additional risk here that would need to be evaluated and considered if this is just completely taken away and included in the capitation rates. Will this be a topic at the next oral health forum?
No, it won't. We discussed it at last month's oral health forum. I think we've presented it there and given it a chance to get the feedback there. I'd like to emphasize that placing this within the capitation rates and removing it from a risk corridor doesn't mean that we simply look at the data from 2024 and apply a standard trend to it. There's still while the data are starting to stabilize, it is still a new and growing benefit, especially on the treatment side. And so projecting some additional increases, both from the maturing body of treatment, as well as from the potential for the change in coding instruction to allow more treatment to flourish, that's something that we can do independent of whether or not we attach a risk corridor to that stream of revenue.
Yes, thank you for that clarification. That's exactly what I would expect. And I think if there's some ad hoc analysis done around that to maybe show what the projection is, that may help the CCOs and DCOs get more comfortable with the change.
I appreciate that. One of the things that I'm taking a note on internally is we can maybe summarize the range of ages that have been screened and treated in 2024 and compare that with what we might think would be possible in 2025 and beyond. If really there is treatment only around a narrow band of age 10 to 12, that would, for example, indicate greater likelihood of increase in treatment in 2025. And contrary-wise, if there really has been a range of treatment and screening, for that matter, between ages 6 and 21 already, that would suggest potentially less increase on account of the change in billing guidance that we've provided.
Thank you, Will. So I'm looking in the chat and looking for hand raises. Don't see any on this topic, but don't you go away, Will, because we'll get to more of your risk corridors later. So what I want to do now is go to the HRSN admin settlement topic, and recognizing that these very small ends for the votes that we were able to get, they're increasingly less meaningful. So we will go to the HRSN admin settlement, and then we'll go to the behavioral health DP and the MLR due date item, because they both have 8 and they're both John. So let's go ahead and get Chelsea and Jake for the HRSN admin settlement removal. So do we have any questions or comments about this topic? So going once. Oh, Mark Lewis.
Yeah, I just want to echo some of the comments that were made at the rates call earlier this week. And that's just the amount of data that is going into removing the settlement. At this point, CCOs are still struggling to stand up this benefit. And really, the amount of data we have isn't a lot. We haven't even submitted the administrative settlement yet. Just concerned about the fact that we're taking away the settlement when we haven't actually stabilized the benefit. And I think if we use some of the same logic that you applied to like the climate and asking CCOs if 2026 delivering the climate benefit looks different than 2024, I don't think CCOs can really say whether or not it will look different in 2026 than it is now, because as I mentioned, we're still stabilizing that benefit. So just a concern about removing that settlement process when we haven't stabilized the benefit.
Thank you, Mark. Chelsea or Jake, any response?
Yeah, I'm happy to respond there. So I think it's already been discussed a little bit about the intent of the settlement. Because we're using a non-risk contract, there's actually a lot of requirements and parameters around what we can pay you in the settlement already from CMS's perspective. It has to be productive admin, means that the admin still has to be associated with a good amount of service for us to settle. There's a lot of parameters on this. This is not a straightforward settlement, meaning you spend more money on HRSN and admin and we can pay you out. There's a lot in there, and the contract kind of creates that allowance for us to get that back and forth with CMS. This isn't just any admin you spend on HRSN, we can pay you. What makes it really difficult is because we can't provide a lot of assurances there, it causes a lot of back and forth with CCOs. And I will say the settlement itself is challenging. If we go through the settlement process, meaning we get your submissions at the end of this month, and there's some surprises and we need to talk about that, I think we still have some room to get this. We want to make sure this is on the table for 26. The settlement itself and how risk mitigation works. Generally in our work for risk corridors, other things that include service, much more straightforward from a CMS perspective than the non-risk admin world. And we can talk about that more if people want to. The other piece around this is I'd really like to take the effort towards what the settlement is and talk about what the admin should be for HRSN. So instead of focusing on having settlement cover, let's talk about what administrative surprises or costs exist in the program and really push in that area and talk about what we can do to beef up what you're getting paid in the front versus trying to hope that the settlement's going to work out with the limitations that CMS exists. I'd much prefer to push on how the admin is built in 26 than to retain the settlement, but I think we have to pick which way we go there. So just throwing that out there, I really want to see and hear from CCOs on the admin development. Is the variable working? Is the variable enough? How is the cash flow working on admin related to your partners? We're hearing a lot about how providers admin is beefing up. How are you downstreaming your admin fee to your providers that are doing a lot of administrative work or not? And how do we change that cash flow model is really where I'd like to focus versus trying to say that this settlement can protect you if it costs a lot more on the back end, because there is restrictions with CMS. And again, this is also really under scrutiny because it's under DSHB money. This is not regular matched Medicaid money. And so there's a lot of risks in this settlement already. And I'd prefer to talk more about the admin development in 26 if we can move there versus retaining the 26 settlement. That's my discussion on the item. And I know that a lot of concern about taking away something that feels protective in an HRSN landscape when things are shifting so much is a little scary. And I think one of the pieces overall, all of the financial items, and Cheryl knows this up and down, a lot of these items we have to put on the contract table before the rates and before submissions are in because of the contract timing. And so let's just say that this one and all the other financial items that are contingent on rates, we need to see the data too. And so understanding the data pieces are coming. We have to put all these items on the table prior to data, and that can be challenging. That can feel too early. But if we miss the contract timing, then we can't add it later. So there is kind of a little bit of a trickiness that happens. Directed payments is a great example. We have to do a lot of changes to the contract right after the rates are built in July to get it into your final draft for August, once we know directed payments items are finalized. It is a very difficult timing for finance items for contracts generally, but we get more feedback that way. And I think it's really important that we're staying transparent and upfront on all these items and gathering your feedback. I see, Mark, did you have any follow-ups, or I'd see another hand too.
No follows up. I appreciate what you're saying there, Chelsea. I just want to reiterate the fact that it's an incredible financial lift for, I'll say, our CCO around HRSN. And I get the impact of the source of funding for this or the settlement process, but it really is, I'll just say, stressful from a CCO financial perspective to know that that's going to be taken away in an environment where we're still standing up that benefit.
Agreed. I understand. Okay.
Hey,
go
Chelsea,
ahead.
there's a comment from Josh in the chat that you might want to take a look at.
Yeah. Okay. Changes in the backwards changes have Josh, are you talking specifically on the admin build related to HRSN? Okay. So in terms of the administrative build for the non-risk component for HRSN, that is completely separate. And it doesn't have, it doesn't rely on the tier, like the same structure of the regular rate work. But it does have some similarities in terms of how it's tiered, but there is a difference. One of the biggest differences is profit and risk contingency. We can't put that in your HRSN admin because you have no risk in the non-risk world. So your admin is actually a little bit more restricted on the non-risk side than it is in the rate setting. But I'm not sure if that's exactly where your concern is. It sounds like there might have been comments from Mercer in the rates worker meeting, and I'm sorry, I've been out unfortunately due to emergency this week, so I apologize for not being on that, and I'm happy to talk to others, or we can bring this back up at the rates meeting after Laura and I kind of debrief. But this is my first meeting back, so still trying to catch up and make sure we understand. Want to hear the comments, want to hear the details, but it might be best in writing just so that we can work through that. But again, I will say that I would much prefer to push on the admin numbers than have a settlement, just because of all the restrictions that exist in the non-risk world that we're currently in for HRSN. I'm not sure if I answered your question, Josh. Go ahead.
Oh, I was just gonna say I totally understand and no big deal. I just kind of wanted to red flag it because there was kind of a combination and a comment that effectively was like, well, we're just gonna use HRSN or this isn't really any different than a medical benefit. And I just kind of, as we're trying to work through this, they are very, very different. So I just I think that that's just something to flag for the internal review for all of these things. Because I think that will understanding how complicated each of these new HRSN benefits are is I think a really vital part to rate development. That includes in this piece, that includes in some other spots. So that's all I was trying to highlight. Just that this might be a really good spot for us to maybe level set a little bit from your team and from the CCOs.
For sure. One piece that I think will be super helpful is that we'll have our first admin settlement for this rate development for 26 to see what the differences are. But again, that's before housing came on. So having some discussion from each CCO, I mean, mostly before housing, we have 2 months, but I think having a discussion from the CCOs with that submission of what they're seeing in 25 or how things are going on the ground, I would heavily encourage that. But this is really our first view into actual costs on admin that we haven't had. So I do think that that will help provide the data and the backing for us to work through those items. I see some hands up too. Thank you, Josh. Appreciate that.
So Larry, do you have a follow-up question, or is it the original hand raise?
Oh. Larry, I don't think we can hear you. Cheryl, can you hear him?
No, I can't.
Okay. Oh,
yes,
there
you are. So do you have a follow-up, Larry? Oh, okay. Now I guess, so Laura.
My God, yeah, go ahead, Laura.
Yeah, I heard Josh's comment and I see it in the feedback about sorry, Laura Bass from Mercer. So I was the one that talked with you all the other day. So Mercer does definitely appreciate that HRSN benefits aren't your typical medical benefit, and we've been listening on this call and already understand the some of the commentary about like provider or members not necessarily going to see their doctor till they're sick, but every member being happy to have a generator. So we do appreciate all that. To reiterate what Chelsea said, this settlement process is going to be everyone, Mercer and OHA's first real look at what you've really spent on admin for the first 10 months of climate. And I'm sorry that there may have been confusion. Mercer's approaching an admin buildup like a medical benefit. I'm trying to draw comparisons between a new nutrition benefit coming online the same way a new drug comes onto the market. So we build up admin in a similar way that we build up other things with data and accounting for program changes. And we are working very closely with OHA to track all of the new benefits coming online, all of the new rules in the contracts. I started listening to the YouTube video that was posted from the meeting earlier this week. So Mercer is catching up. These are different from your normal traditional medical benefits, but I'm trying to draw comparisons in the methodology, if that makes sense.
And thank you, Laura. I fully agree. I think admin buildup categories are similar, but maybe the numbers associated with each category are very different. One of the things we saw was network adequacy and network work was much higher in the HRSN build than we have for others. So a couple things also to think about the percentage and how it relates to service. It's not going to look the same as medical, where we're more between 8 to 10% on admin for medical. Things are much higher on the HRSN side, depending on the service that you're looking at. But Erin, is there something you wanted to add about what is different that would be helpful for Laura and I to hear about?
I don't need to beat a dead horse. I just think it's really dangerous to draw a direct correlation there, because the work that is underpins adding a new code or adding a new pharmaceutical on the medical side, and the work that it takes to stand up an entirely new benefit that cannot be leveraged with any of the economies of scale that we have internally, that are entirely different skill sets, new staff, new relationships. I feel like I continue to hear things that make me feel like there's a significant disconnect in what it actually takes to do the work and support the services in the way that they're designed. And because of that, we have incurred significantly higher costs than we are reimbursed for. And I feel like that has been diminished. It has been ignored despite much feedback to the contrary. And so this may not be the time or the place to have that. And I hear your invitation to provide more feedback on that, but it just concerns me when now the second time this week we're hearing it's just, it's similar to we're taking a similar approach even to how we would add a new service on the medical side.
Erin, can I ask a follow-up question to you on that? Because I think that I'll just be very upfront. I've been hearing a lot of the administrative concerns, and a lot of them are at every different level across HRSN, and that's a really tricky thing in how the model is being built to be, consistent-ish with medical standards, right? Like I think having those differences of reimbursing for service versus more grant-based service delivery that existed in this world has always been a huge challenge. One of the things that I just wanted to follow up as a question, because we did walk through a little bit of the admin categories, is it the categories that are we missing a category for admin development, or are we missing what number should be associated with those categories, or both?
I think there's opportunity in both.
Okay. I would love to hear about some of the different categories. That would be helpful. Well,
and more specifically, and I am not an actuary, I'm over my skis a little bit in your space. I don't know enough to be dangerous, but what I feel and what I observe from where I do sit is that there seems to be a disconnect in the actual in how we quantify the workflow, the staffing required, the amount of hours that it takes to complete the requirements as the program is designed. And so there's a math problem there. And that's not something that actuaries typically work with, and something that is this hands-on, that is, requires the amount of just administrative lift, operational load that we're having to carry. And that's where I feel like the disconnect is. So I don't know if that's a category or a number or a combination thereof.
Yeah.
But I feel like we need, my invitation to Emma has been, can you have your staff sit down with our teams that are on the phone to just understand what it takes to complete all of the requirements, get the documentation in place, manage all of this with someone who has severe and persistent mental illness that's trying to tick and tie their phone bill with their utility bill, with their rental payments and their landlords. It's just, the complexity is extraordinary, and what we've been paid simply does not support that complexity.
It's really helpful. So in terms of defending changes to admin and how admin is built, one thing that we always have to think about, which I will bring into this space, because I think we need a partner on this, is how CMS looks at admin differently for HRSN services. And so that's why I ask the category versus the number piece, because if there is a category that we can concentrate and discuss in a different way than what is base medical categories, that may be helpful. But that also is something we need to think about as it goes to CMS for review and approval. I only say that just because as you consider your feedback and how you provide the definitions and how you provide kind of the places of the pain points, if you will, just keep in mind that we have to defend this all the way up to CMS because it is on their dime in terms of where we're at. So that's just a comment because the more we can defend it, that data piece that we'll get at the end of this month, if you add discussion items about 26 related to admin, all of those pieces will be very helpful in how we defend any changes or adjustments for 26 for admin generally. So really appreciate that feedback though. And please bring it in. Laura, did you want to add?
Yes, I hear comments and I see in the chat all the agreement with Aaron's comments about the dollar amount being paid out not being adequate because the benefits are so different. I think my question, in addition to Chelsea's and kind of related, there's the question and the invite for info that Chelsea made for what categories, what categories of admin exist. And I'd love to hear that. And I'd also just love to hear feedback on how, on the methodology, because put very simply, if we took your CY24 admin reports and we applied trend for things such as increase in how much employees are paid, so increase in staffing costs applied as a percentage for trend, like a trend, and if we add on dollar amounts, hopefully of a higher amount, because I hear you, this is a lot harder. But if we add on dollar amounts that relate to new services coming online and having to build a whole new provider network around fruit and vegetable benefits or pantry stocking or so on and so forth, what else do you all see in the methodology that would help us get to a calendar year 26 admin rate that is different from a trend or a dollar add-on?
Go ahead, Nora.
I'm not sure this is totally responsive to the question, but what it makes me think about is the CCOs have significant costs associated with, for example, the housing benefit, and the plan is to have the settlement. But we currently don't know if we have X million dollars, how much of those dollars will be reimbursed to us and how much we will be in the hole. And so I think there's a bit of concern because a lot of that information that that will be used for the settlement that is being asked about what are these costs, are embedded in the work that we have done on the administrative side and the work our partners have done on the administrative side that we're sending for the settlement. So I even probably more so than Aaron, I'm not an actuary. So I am hesitant to speak to what those categories are in a way that's useful for that analysis. But I think both that's where a lot of that information will be is in the settlement information.
Nora,
And
sorry, I just didn't hear.
And
the
we're
last
worried. Oh, okay. Yes, the information should be in that settlement data, but also, we have real concern when we're told, oh, well, it'll go into the rates, but we don't yet know whether we're actually going to be made whole for the millions of dollars that we're holding in administrative costs that haven't been settled yet.
Completely hear you, Nora. And I think In terms of predictability, it's actually easier for us to put it in the admin number and the dollars that we give you than it is in how the settlement is built. I'll just be very frank with that. I'd much prefer to talk about what we give you in the front end, get that approved from CMS and put forward, because that is risky for you, right? We'll have 24 and 25 in that state with the settlement. For 26, I'd like to really focus on the admin fee and the cash flow and how it's working for you on the ground. And that will move the conversation, I think, in a good place, and we'll have data to support whatever conversation we have. The only piece that we don't have is a lot of data on admin related to housing. And I feel like that's the piece that's really challenging, because we'd only have 2 months of your implementation for housing in 24. So the more you can help us in that area, the better. But I think that you highlighted the risk that I see with the settlement is that there is some parameters that go against it and how CMS will evaluate and what they'll allow us to pay out. So that creates not unpredictability for CCOs, and much prefer to have predictable payments out the front end without a settlement, and then that can help move the needle versus what we're doing right now. Understanding the settlement was built for a lot of reasons, because we didn't have a great implementation schedule at the time. We were on-ramping quickly. We wanted to have some cover. I think moving away from that and talking about the numbers and the build and the methodology is a good move from our perspective. But that's why we're having this conversation, this TA, this feedback, because if the settlement is more important to keep, then I think that's something we want to hear from all of you. We just want to lay out the risks and how to move forward. But we will be excited to see your settlement submission at the end of this month, along with a variety of other submissions that I know your finance team is working on, and I bet a lot of people on this phone are. So I just appreciate all the work in that area, because a lot of things are due on April 30th. Okay, Cheryl, we're getting close to time.
I know. I
wanted
have
to-
a plan. I have
Okay,
a plan. Okay, so thank you for that, Chelsea. So what we're going to do is I'm going to basically go in the percentage order in my list here and invite people to quickly raise their hand if they want to discuss anything related to that topic, and then we will move on to the next. So please don't even go to the chat, like raise your hand if you want to say something, okay? So behavioral health directed payments. I'll count to 5 in my head. Did someone put in the chat? Okay, yes, exactly. Lightning round. Okay, I see no hands raised. MLR incentive payment due date. Okay, no hands raised. That may be counting too quick in my head. So number 5 is the adding the GME to the CCO rates and contract. Okay, that looks like a no. Even though I got 0 votes in the limited number of votes, the CLSS expansion for physical and dental. Okay, so now we're down to the last 2 risk corridor items. So the mobile crisis risk corridor removal. Okay, and now our last item, the Healthier Oregon Program risk corridor updates. Okay, I'm not seeing anything. So, with that, a few housekeeping things, just to wrap us up. Oh, Josh, yes, please go ahead.
Sorry, I wanted to, can we speak a little bit more about the Healthier Oregon program risk corridor changes? I particularly, I'm a little concerned about, or confused, not concerned. How will this kind of look? I'm thinking kind of from a reporting side of things. I mean, I think with our federal partners doing our federal partner things, like what that could potentially, if there are any pitfalls that could come from merging these things, as Will had said, I guess Tuesday, because I feel like we've had 3 of these meetings this week. But I'm just kind of curious to know, like, can you maybe, Will, kind of explain through that? I think there was some concern also expressed in the rates meeting as well.
I don't recall any concern expressed there, but I did, I tried to make clear in the rates work group meeting, and I'll reemphasize it here, the federally matched emergency and pregnancy related services that are technically Medicaid, those will be under a separate risk corridor, as has been, and separate capitation rates, as has been the case since the implementation of the Healthier Ordering Program. And that will continue in 2026, and frankly, as far as I know, indefinitely beyond. The separation of those Medicaid benefits, that is, from the non-Medicaid benefits. The only change that's happening or that we're proposing for calendar year 26 is to simplify the formula that's used on the non-Medicaid side, the state-funded benefits. And that formula will happen to be the same as the formula that we're using on the Medicaid side, but the data that go into the formula will be entirely different. The Medicaid data, revenue and expenses will go into the Medicaid risk corridor formula, and the non-Medicaid data, revenue and expenses will go into the non-Medicaid formula, and there will continue to be a strict separation between the two. Does that address your question?
That is helpful. Thank you.
Thanks.
Thank you, Josh. Thank you, Will. Jenna.
On a similar note, but not exactly related to the parameters, because I think simplifying the non-Medicaid is great. I would like to reiterate a previous request to have the shadow pricing results, a preview of the shadow pricing results before the final settlement template. I understand that that is a lift on the OHA side, but there's just so much uncertainty in the settlement amount until we know exactly how, or have a good idea of how that shadow price is going to be conducted. And, you know, during the template review and when we provide back our submissions, we're really doing a lot of work in terms of validating the figures and making sure that the data is complete and accurate and documenting all of that. And to go through the process of also trying to figure out what the methodology was that was applied to the shadow pricing and validate that all in that limited time frame, it's just very challenging. So it would be very helpful to the CCOs to have a preview of the shadow price and the methodology at a previous point in time.
I appreciate that feedback. Just this probably be reiterating a little bit of what we've shared on this before. A couple elements that make that a difficult request to fulfill. If it was easier to fulfill, we'd be eager to do it. But a couple things that make it difficult to fulfill. Number one, the repricing module, if you will, is just sort of it is a separate process of its own. Like you say, so it takes a considerable amount of work, kind of a whole series of queries and programming in a database just to get results. It would also operate on incomplete data. When we send you interim results based on data to date, anything that we build off of that in terms of repricing will change with the final. One other data point that you might consider referencing is, there's this newer fee-for-service equivalent data point that CCOs have been building and transmitting to OHA. That might be something that's worth considering as a benchmark for your own internal pricing for sub-zero paid or sub-capitated claims going into the settlement. Have you considered looking at that?
Yes, we actually look at a variety of data points, including repricing at fee schedules and trying to mimic historical patterns where it's an average CCO rate that, don't have a lot of clarity because it's not our average CCO rate. And, just we've tried to back into the methodology and have actually put in a significant amount of time and effort to do that and to make our accruals as robust as possible. But I mean, I totally understand your points. I think getting those interim files with the data, we still want that. But even if it was, let's say, like we got a preliminary reprice, then a couple months after that, once time could be spent on the OHA side to do that reprice and we get that data on the incomplete encounters, I think that we would still have a lot of value in that because it provides us a chance for validation, especially as these populations grow and the accruals grow, for audit purposes, having something to benchmark against would just be very valuable for us.
Okay, I appreciate that. One final question, if I could. If we separated the repricing timing from the data files timing, the data files we try to release around February to give you advanced work in front of the 31st submission date for data. If the repricing came later, what would be a date for that repricing that would still be of use for your construction of financials and any other financial reported needs?
Yeah, I was more so thinking, I know that there's a November data release that is even more limited, but if that was provided around the same time, so that using that November data release, if we got that, let's say, end of January, early February, I think that that could be still valuable. Obviously, we would have to have our accruals done, so it would be more valuable to have that prior to year end, but it would just give us a way to gut check where we were at and make some adjustments.
I'll take that back to the team. Appreciate the conversation.
Thank you, Will. Thank you, Jenna. So we are definitely at time. So I'm going to wrap up really quickly. I want to thank you all for your time and attention, all of our CCO colleagues and my OHA colleagues. Thank you for spending your Friday morning with us in this way. The meeting has been recorded, so I will send you all the link to the recording once it gets posted. That might not be until Monday. And lastly, if there is something that you wish you'd said, meant to say, forgot to say, you're still welcome to send written input to the contact person listed in the slide deck. If you could do that next week, that would be super helpful. And with that, I think we're done, and see some of you all at the and just one sec, Chelsea. And I'll see some of y'all at the HRSN office hours next Thursday. And we are looking at scheduling the final office hours on May 2nd. That's also Friday. So yeah, Chelsea, did you want to say something real quick?
Just real quickly, if we can request that the financial items be sent to the actuarial services inbox, that would be really helpful, consistent with how the rates work group feedback comes in, just so we can keep everything together, because we're managing multiple meetings, getting feedback on this.
It's a lot, totally. Thank you all so much. Take care. Enjoy your weekend, and see you next time.